At the outset, I would like to thank Professor Azad for giving me this opportunity to be part of this course here. I'm going to talk about the peculiar problem which we face in this country and many developing countries are facing of retinopathy of prematurity in heavier babies. I think right from the beginning when we, did some studies and the first prospective study way back in 95, I think the incidence was quite high, and we did take arbitrarily 1,700 grams. In fact, I must say that subsequently, this was the study where Claire Gilbert had written a editorial in VGO, subsequently picking up our high birth weight babies, that it is happening in those. And you can see some other studies subsequently where 2 kg has been taken. I think this was one landmark publication from our group, which when Anand Vinekar was with me, he did as a thesis, but it wouldn't get published. He did probably his thesis not in 2007, but way back, maybe 5 years earlier, because everybody thought we are talking something else. It's not probably ROP. So what is significant here is that 16% of the babies, you can see here, they were more than 1,750 grams, and 6.5% were more than 2 kgs, and the period of gestation, about almost 22%, was more than 32 weeks. So whatever the Western guidelines strictly being followed, I think so many of them would have gone blind. I think subsequently we have Subhadra is here. They had a paper in VGO in 2011, and Narendran is here. They had this paper published last year, and we published in Retina this APR paper. I think I'm very fond of projecting this one all the time. You have to look at these 3 studies from our country, that the average age, average period of gestation and birth weight, as compared to the 2 one from USA. This is Michael Tracy's group on APRP, another one from Azuma from Tokyo. And you look at the difference, that is what is important. See, the mean birth weight for us here, if you look at, is totally, this study by Shah et al., this is the Linden group, is 1,500, and for us, and these are extremely tiny babies. So is the period of gestation. So that's where the problem is. So we have something much more going on and different going on because of the variable reasons. I think we were looking at all our RECM pictures, and I observed that there is a mixture of both stage as well as some of other things happening, which is not exactly the way which what we are seeing and we can put into a particular stage. And here also all these babies, they were older, heavier, and that's why probably they were forming a mixture of both stage and APR. And so that is what was happening. Some had like mat-like proliferation, some had like already a demarcation line, and also the flat USs. The problem is, we do get all of us, as some of us who are very busy in this kind of work, every week 2 to 3 babies like that. And I think what we did, we collected these and we put up a little study, which is published in Ophthalmic Ophthalmology. And you can see here that 15% of the babies were more than 1,500 grams. These are talking the stage 5, which has come to us late. And the median age of presentation was 7 months, and 86% were never screened. And that is where we are. And you can see almost 75% were self-record, when the parents realized that their child is not screened. So that is where the whole problem is. So screening criteria, I think Subhadra is here, Vinekar, and some of the neonatologists of our country, they put finally, which is now 1,750 grams and 34 weeks. That is what, and you could screen up to 2 kgs if the baby is receiving more ventilation or is much more sick. And since it's a case-based, as talked to us, this is one case here. I think that this was 1,620 grams, 18 days of session, period of gestation was 32 weeks. And this is the case, you can see, you have a APRP-like picture, but not typical. I have a lot of pictures here for this particular baby. And what you have is, you see these kind of, as if something has been stuck over the vest. And this is totally different. But this is typical, what you would expect in a case of APROP. But then this is not everywhere, and here it is probably trying to form like a stage. So that's, we are seeing all different. And you can see here again, something as if it has been stuck over this, and you can see much more clearly in this picture. And look at these loops. These huge loops, I think we are seeing more and more. I'm seeing them much more in these babies coming from SNC. And so I think they are probably exactly oxygen-induced, that is what's happening, and they are very posterior. Of course, I think very nicely, Parijat has shown these are all avascular. We did laser, I think right eye we were lucky that it regressed with little infection here. Left eye also regressed, this was laser, you can see these scars there. But in this particular area where all that is, it formed a lot of this fibrovascular tissue and fractional bands. I think this case underwent 23-gauge vitrectomy. This is probably maybe 3-4 years back. And we did remove all this. So, once these bands were removed and we did the vitrectomy, which was a lens-sparing vitrectomy, I think that's not really the idea here. So you can see this is the result you have after focus 4A, this became like that. Another case, and you can see 2200 ranks. So you can't see a worse disease than this. Look at this. I mean, you have almost these vessels here and 2200, 2.2 kgs for the baby. And this was heavily lasered. This is the other eye, and it has even a lot of hemorrhages, including one sitting right near to the macula of the fovea. And this was also heavily lasered. And somehow, these cases probably, which probably may be oxygen used, they do behave better with laser. This is another impression I have. We have not done any study, otherwise probably such a severe disease, it will now, but you can see everything here has become, now the vessels are straightened up, they are cleaned, and the disease is regressed. And this is something which Parijat was showing, that we get some spots put here, periphery is not treated, and not then the baby is not sent. You can see this is already becoming narrow. So we did treat it again, and it is already, you can see, narrow. This eye, he was lucky, and you can see always what happens. If it separates, the arcades start opening up. That is what has happened here as compared to that. But other eye remained the same despite our laser. So we didn't do surgery because it sort of remained absolutely stable. And this is another one, late presentation. Again, you can see the birth weight, 1550 grams. And here, again, once they sent to us at that stage, arcade is already narrow. This is 4A. And the laser uptake would be poor because it will not come closer to this. And that's what happened finally. And you can see it has again become very, very markedly narrow, the arcade. And it has gone on to almost like a 4B, and we had to do lens-sparing vitrectomy. I don't know, that's why I put this, that what is the right time for a vitrectomy in such a case. So I can go on and on with many cases, but what is happening for us is that high birth weight babies develop severe ROP in India. And I'm telling you, with SNCUs, you all going to see them much more. And you will see them something like what I said, hybrid or APR pictures. So modified screening guidelines need to be followed and implemented, what has been put forward by along with National Neurology Forum. As ROP, blindness is preventable in majority of babies, identify these babies, and also include these guidelines and treat them properly with laser. Delayed screening results in permanent blindness or severe vision loss. I have shown you that, and that's what is a problem for us at this time, and which somehow we need to rectify at this stage. Thank you very much.